going first?
I don't know. Or we're just gonna go back and forth.
Okay. I'm going to introduce you.
Okay. Do you want to wait for the YouTube live countdown? We're not there yet. It'll take 3 minutes. 2 minutes now.
What?
Oh, we're not
He's
live
got.
yet. No,
He's got a countdown.
he's got a. So whenever you start an event on YouTube live, it will send out a notification that it's going to start, but then it waits 3 minutes before it actually starts. So there's a 3-minute countdown timer for everyone to get filtered in and get ready to launch.
He's never told us that. No. Okay. There's probably no reason for me not to start at 2 o'clock.
Just that the people at home won't be able to watch early.
Maybe I misunderstood what he said. What was he saying?
He said he would.
He'll give us
He had a 3-minute countdown that he had to start.
Okay. 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 Typically uses a high sign anyway. We've had as many as 75 for days. That was pre-COVID. Kind of went to zero for a long, long time, and then we had about 30 here a couple of months ago. First or second one we did live again, but they've continued to do it both live and then promoting it into their in-house TV, so the people at home can do it. Okay. 30 seconds. Okay. Good afternoon. Nice to see you all here. I was just telling these residents who haven't been here that pre-COVID we weren't exactly packing the house, but we got 75 one day. So we'll get back to that sometime when everybody feels comfortable again. And it's still good to be on this side of this pandemic, isn't it? We're not out of it, but Butterfield is as close to being away from it as any place I know of. And I brag all the time. I was telling Dr. Helen this past week that I just think it's so remarkable, and I'm so proud of Butterfield Trail Village. 99% vaccination rate. I just defy anyone to top that. I haven't heard anybody even close. So, and what great protection that gives. I wish the state of Arkansas were anything like that. We'd be breathing easier, wouldn't we? So it's been a tough year, and all of y'all, everybody here has proven they're tough, just weathering it, right? Just coping with the stress of this. And there's no good place to be in a pandemic, because it's like one patient said to me, I asked him how he was coping and so forth, and I said, I'm so sorry you're having to go through this. This was early last year. And he says, well, last time I checked, it's affecting everybody on the planet. It's not just us. But so maybe there was no perfect place to be during the pandemic, and certainly nobody escaped it, exposure. But I would maintain that Butterfield's about as good a place as you could be. And boy, y'all all did it right. When they said shelter, y'all sheltered. And when the vaccine became available, y'all did what other places haven't done. And I'm just so frustrated that the whole public hasn't received it that way. You know, there wasn't a question about who was going to take the polio vaccine, was there? It was a given. If you knew about anybody with polio, you weren't going to fail to take the vaccine. Anyway, welcome, and we're so glad to be having these more face-to-face all the time. still being televised on the in-house TV if you're at home. But glad to see a great group of people right here and still coming in. So as you know, once a month, and we've been doing it twice a month before COVID, and I think we'll reinstitute pretty soon the second program such as this each month. We do this one, which is a specific medical topic, something to do with health and aging, which is a big category of things. We do this a presentation that the resident physicians, the young doctors that are working with us out here, make a presentation on. And then the other one that we were doing for a while and we interrupted was one that I kind of like to call just an open mic. It's just come with your questions and let's talk about whatever you want to talk about. And we'll hopefully have some answers, and undoubtedly we'll have some things that we can just give you our impression, our opinion, or we'll look it up or we'll research it if we don't know. But it still makes for a healthy discussion about things that you want to hear about. So I think we'll try to reinstitute that pretty soon now that we've got people face to face. Because if you don't have people face to face, it's hard to do that format. I especially learned that because there are fewer questions on the phone. You know, we invite people to call in, watch it on TV, and call in on the phone. Quickly figured out that wasn't happening. I'm not sure why. I would think it would be more inhibiting to do it, to stand up in the audience and ask a question than to get on the phone. But that's the way that works, so that's why we didn't keep doing that. Well, I'm really pleased with the doctors we have with us this month. You know, the blocks that we have here are 4 weeks. They're not an exact month, they're 4 weeks. So that throws us off schedule for some things, including the announcement in the bulletins, the newsletter that you get out. We have to get them in earlier and earlier some parts of the year. But our resident physicians that are with us this year, you see their names on the board. Dr. Joseph Malhis, who Joseph is just starting next week his third year with us, his last year here in the internal medicine residency, and Dr. Dalton Hoos. So let me tell you about Joe's background, Dr. Malhis. He tends to promote the idea of just calling him Dr. Joe because people stumble over the pronunciation of his name. I kind of think we ought to all try to, use a person's last name and learn how to say it, but he's so good with just Dr. Joe, that's what I think it's come around to. Well, Joe is a native of California. Did his undergraduate work at pretty good school, I hear, University of California, Berkeley, really highly rated academically, and went to medical school at Kansas City University, an osteopathic medical school that has quite a good reputation, especially with us. We've interviewed many of their graduates and have had some here. So as I say, he's just starting his third year. Dr. Hoos is a native of Kansas. Where in Kansas? Parsons, Kansas. I bet there are people in here that know Parsons, Kansas. Came to Arkansas in college, went to a wonderful, wonderful college, my alma mater, Hendrix College in Conway. Yes, of course. The Culvers know about it. They know a lot about it. The way it was built, how it was built. Exactly. It's a great, great college. If you're ever in Conway, Arkansas, you need to visit that campus. It's absolutely beautiful campus. Dr. Hoos met his future wife there. He's technically still not engaged.
Technically, yeah.
Almost engaged. She is a classmate who will be out here next block, coincidentally, Erica Hasu. And I've heard rumors that Erica runs circles around you, but we'll see. We'll be the judge of that. Just kidding. Dalton's been a wonderful resident to work with. Both these guys have, and so today they're going to be talking about chronic kidney disease, which is a fairly common issue for all of us as we age. And I'm anxious too to hear just what they're going to have to say. So I'm not sure who's going first, but
I'll start out. Okay. Hello, like Dr. Wright said, my name's Dr. Hoos. This is Dr. Joe. We have just a short presentation on chronic kidney disease for you guys this afternoon, and then we'd really like to open it up and let you guys kind of guide the discussion. So starting off here, just a brief definition. What is chronic kidney disease? So chronic kidney disease is abnormal kidney function that has persisted for at least 3 months. Any sooner than 3 months, and we call it acute kidney injury. But after 3 months, we decide that that's a chronic condition. And we monitor the abnormal kidney function, or we define the abnormal kidney function as a decrease in someone's estimated GFR, or glomerular filtration rate. It can be an elevated creatinine level. It can be an elevated level of albumin, a protein that our liver makes that gets excreted into the urine. If that level is high, that can define chronic kidney disease. And then just a last definition is end-stage renal disease, which is the very end stage of chronic kidney disease, as its name might suggest. Take over.
So when it comes to screening for chronic kidney disease, we don't really have typical screening routine for this specifically, because it's actually, according to the U.S. Preventative Services Task Force and the American College of Physicians, when you don't really have symptoms for it, you don't necessarily need to be screened for it, but typically a screening would involve a urinalysis, which would check your creatinine levels or the albumin levels in your urine, as well as we would do a blood test to check your creatinine levels, which we mentioned before. But hopefully after this lecture, you want to go immediately to us saying, can I get my kidneys checked?
And so when we talk about making the diagnosis of chronic kidney disease, the first thing we would notice is when we draw your blood, one of the lab results that we get back is an eGFR, an estimated glomerular filtration rate. If we see that this has been low for 3 months, then we'll get to that. That's one of the criteria we can use. A second one is if we do a urine test and notice that the albumin levels, like I mentioned, were elevated. If the urine albumin levels on just a random urine sample are elevated, then we might ask you to do a 24-hour urine collection. We'd give you a jug, you'd take it home, and for the next 24 hours, collect all your urine. And we would check the albumin levels in that sample as we go through the day. Our body responds to the different times of day differently and secretes albumin at different rates. And so we can get a better estimation of what your body is doing by checking a 24-hour urine albumin. If those criteria have been met, one of those criteria have been met, either the lowered GFR or the 24-hour urine collection, then we may need to do something else. That E in the eGFR is just an estimation. It's a mathematical formula that's been developed for the average human, but of course no one human is average. And so we may need to calculate a specific GFR for you based on your height and weight and your creatinine levels. And then if the problem still evades us, so we can recommend a kidney biopsy. Send you to a surgeon, have them go in, take a little piece out of the kidney and look at it on a microscope slide and see if that can give us a little better picture of what's going on. The symptoms of chronic kidney disease are something that everyone is concerned about. Unfortunately, they are pretty non-specific. The body only has a handful of ways to tell us that something is wrong, and for chronic kidney disease, a lot of those are present. Things like edema or swelling, we can see that in chronic kidney disease, but we can also see that in conditions like heart failure, or if if the veins in our legs aren't working so great, fluid can pool and cause swelling. So just because you have swelling isn't necessarily a sign that you have chronic kidney disease, but it's just something that we need to be aware of, something that we're kind of piecing together behind the scenes. And that's true for most of these symptoms: fatigue, nausea, loss of appetite, insomnia, irritability. The most interesting one, personally, is this last one on the bottom right, this uremic frost. We'll talk about why this happens here in a couple of slides, but as the kidneys start to fail, you build up phosphorus in your body, and sometimes that, when it gets to a sufficiently high level, can come out in your skin. So instead of sweating salt, you sweat phosphorus, and it leaves this kind of white powder on your skin that is collectively called uremic frost. So.
And so we're going to go over the stages of kidney disease, and this is something that you probably all have been wondering about, because I've heard multiple comments saying, well, I'm told that my GFR is 45, or I am stage 3. What does that mean? Well, that's what this diagram is for. So technically, all of us have at least some form of stage of chronic kidney disease. I have stage 1 because it's based on our glomerular filtration rate, it being greater than 90. If you're actually greater than 90, despite the fact that it's stage 1, you're in a good spot. And that is considered normal or high functioning. Now, as you progress down to stage 2, you're looking at between 60 to 89. And even if you're above 60, you're still in a good spot. And so, although it's decreased, you're not really in that stage of significant chronic kidney disease. It's when you hit stage 3. And stage 3 is pretty broad, so they actually split up into 2 sections. So stage 3A, you're looking at your filtration rate of 40 to 59, whereas 3B is 44 to 30. And you could think of it as almost like a percentage. Yes, filtration, because the job of the kidney is to filter your blood. And so when the filtration rate isn't working as well, that means you have more byproducts and waste products building up, which is what creatinine is. Mm-hmm. In a typical blood test. Yes, so when we do a blood test referred to as a BMP, or a basal basic metabolic panel, we're looking at your kidney function, which includes checking your GFR. We also check your creatinine, which is the waste product. And if you're not filtering as well, then your creatinine levels will go up. And as you progress, you can get to stage 4 when your filtration rate is 15 to 29. So think of it as almost like a percentage of function, 15 to 29% of what it should be normally. Now you could see the progression, the kidneys getting smaller. That is not an accurate depiction of it. Your kidneys may scar as it gets to that stage, but won't necessarily shrink and shrivel up. Just FYI. And here's another diagram kind of specifying when it comes to your stages and looking at the albumin. So we talked about creatinine before, and when it comes to albumin, it's a protein that helps with fluid osmolarity or osmosis in our system. And so when you tend to urinate more albumin, you're not keeping as much protein in. And that albumin tends to be kept in our kidneys normally, but when you have poor filtration, it'll get on through, and so you'll notice more protein in your urine, which is another sign for there might be something wrong with your kidneys. So you can see with the red in the diagram, with grade or stage 5 kidney failure, then you have a significantly increased amount of albumin, which you can see is greater than 300 milligrams per gram.
And so here is a pie chart listing some of the most common causes and associations that we have with chronic kidney disease. So obviously the largest section here, that red section, 42% of chronic kidney disease is caused by type 2 diabetes. And I'll let you go ahead and read the slide as the percentages go on and get smaller. But if these conditions are things that you have, then chronic kidney disease is something that we're watching for, and that you might want to keep on top of us and make sure we're watching for it. Probably the most common one as we continue to age is high blood pressure. That's kind of a natural product of aging, developing high blood pressure, and so it's something that we're keeping track of. When we ask that you keep your blood pressure down, around 130 systolic, that top number, our main goal is to prevent chronic kidney disease. And so there, like I said, the blood pressure goal, less than 130 on that top number, less than 80 on that bottom number. Keeping your blood pressure under those numbers really helps ensure that you don't develop chronic kidney disease. We use some medications to help out with that. If you're on lisinopril or losartan, those are medications that can help slow progression once we've noticed that some chronic kidney disease is developing. Medications like HCTZ are fantastic at keeping your blood pressure down before you've developed chronic kidney disease, but afterwards it works with a different mechanism and can make chronic kidney disease worse. And then Lasix, furosemide, water pill, can help with the salt balance and water balance, and make sure that you're not holding on to too much fluid, and make sure that too much fluid retention isn't the reason why you have high blood pressure.
Now, this applies for chronic kidney disease, but when it comes to acute kidney injury, these medications, when you're sent to the hospital for AKI or acute kidney injury, these are the medications that we actually hold because all of these medications work on the kidney. So you might be in a situation where you were discharged at a hospital and the doctor told you to stop taking the lisinopril or losartan for a certain amount of time before restarting. That is why.
Okay. So while we think of the kidneys as being primarily a filtration organ, right? They filter all the byproducts into urine for us. That's a major focus of what they do, but the kidneys also have several other minor jobs that we don't think of quite as often. And developing chronic kidney disease can interfere with those systems as well. So bone and mineral disorders is probably the largest of the secondary functions of the kidney. So vitamin D is produced in part by the kidneys, or the kidneys modify vitamin D into a usable form for our bodies. And as we develop chronic kidney disease, then the kidneys lose that ability to manufacture or to modify vitamin D the way that they're supposed to. There is a gland, the parathyroid gland, which monitors the amount of calcium and vitamin D in our body and secretes something called parathyroid hormone, or PTH, in response to this. So as the kidneys fail to produce vitamin D the way that they're supposed to, this makes the parathyroid say, hey, start resorbing more, start making more, do your job better. And it starts pumping out a whole bunch of parathyroid hormone. And increased parathyroid hormone lets the body know that it needs more calcium. And the largest deposit of calcium in our body is our bones. And so with the increased parathyroid hormone, the body starts breaking down bones in order to supply the body with the calcium it needs. And so that is another factor that we're watching with chronic kidney disease, is to make sure that your bones stay healthy and strong and you're not at increased risk of fractures. Anemia is another one of the secondary functions of the kidneys. So the kidneys produce a chemical called erythropoietin. We call it EPO for short. And EPO stimulates the body to make more red blood cells. So as the kidneys progress through chronic kidney disease, the kidneys stop producing this EPO, and so sometimes patients become anemic. And that leads to more of the fatigue that we were talking about as a symptom of chronic kidney disease. The screen, it may be a little blurry, but it talks about the prevalence of anemia through the stages of chronic kidney disease. And so stage 1, stage 2, really not a lot of anemia noticed in this stage. They say 4 million people in stage 1 have anemia, 8 million people in stage 2 have anemia. It's really not until we get to stage 3 that we really start noticing this anemia become more prominent. 17 million people diagnosed with anemia in stage 3 chronic kidney disease. It kind of drops off as we get into stage 4 and 5, the prevalence of anemia, just because at that point the body is so sick and dealing with other things that the anemia kind of becomes a secondary concern at that point.
Now, that is not to say that this is the only cause for anemia. Anemia is a very broad term because there are multiple causes for anemia. Iron deficiency is another common one, which is actually independent of kidney disease. Another cause of anemia is also B12 and folic acid or B9 deficiency. We could probably have a whole completely separate lecture on anemia. But just for your information, if you're having anemia, it may be related to kidney disease. There's also a very good possibility it is not related to kidney disease. Okay, and our last slide, and this is just a picture of dialysis, and I'm pretty sure some people kind of associate kidney disease with dialysis, and this is seen when you have stage 5 or end-stage renal disease, meaning that your kidneys are no longer working as they should, and so you're going to need extra support. So there are different types of dialysis, and I have the two main ones listed here. Hemodialysis, that's when you probably, either some of you are currently undergoing it or you probably have some friends who have it, where they go to a dialysis center and sit down for 3 to 4 hours, just having their blood cleaned out, so to speak. And this happens a few times a week, and that's considered hemodialysis. So what it'll do is it'll pull some blood, go through a diacellator filtration system, and then kind of clean up the blood, get rid of all the excess buildup of maybe excess of potassium, phosphorus, calcium, things that the body can't really handle or your kidneys can't handle on their own. And it does not necessarily have to be lifelong. You might be in a situation where you're in the hospital and you just need emergent dialysis because your potassium has gone too high or your creatinine's far too high for just some acute problem. Now, for those who have the chronic disease, then this may be a lifelong sort of ordeal. Now, peritoneal dialysis is done differently. It's actually preferred over hemodialysis, as it is, you don't have to go to dialysis center. The actual dialysis occurs through the peritoneum, which is a layer in the abdominal area, where it can actually be done in multiple cycles throughout the day. So you can actually do this while you're at home. You don't necessarily need to go to a dialysis center. You can actually do this while you're sleeping. So you could sleep through it, which is very convenient. However, there are inherent risks like everything else. Because you're kind of managing it on your own, you need to make sure that you don't get any infections. And there's a condition called peritonitis, which is an inflammation and or infection of the peritoneum. And it will cause really bad belly pain and cause your belly to be rather stiff, and it's not particularly pleasant. However, data does indicate that peritoneal dialysis is actually better than hemodialysis. It's just harder to manage. And then there's also the other type of dialysis, continuous renal replacement therapy, which doesn't really involve anyone here. This is like when you're in the hospital and you're needing hemodialysis, but your blood pressures are too low. So let's imagine like a bigger hemodialysis machine that runs on very slowly. Because when you do dialysis, you're actually pulling quite a bit of blood out of your body, and that could actually drop your blood pressure. So this new device, the CRRT, or continuous renal replacement therapy, can do it slowly in a more manageable way. And yeah, that is the lecture. So we'll open it up to questions.
Thank you. The truth of the matter is I have several questions, Well, I'll start with this question, and that is that you repeatedly mention creatinine and not bun. And that bun creatinine ratio is important, and it enters in, I think, into the figuring of the GFR.
That is correct. So the BUN or BUN refers to the blood urea nitrogen, which is the urea amount in your system. So the creatinine is a protein byproduct, and when we calculate the BUN to creatinine, that will actually give us an idea. That's more seen with like acute kidney injuries when we look at that ratio, because it will tell us there's 3 categories for kidney injury: pre-renal, intrarenal, and post-renal. That has to do with the location. Pre-renal means it's actually before it has to deal with the kidney. So poor volume, dehydration, things like that are pre-renal. Intrarenal would have to be affecting the kidneys themselves. And then post-renal is usually involving the bladder. So sometimes an obstructive issue in the bladder that are not allowing you to urinate. And so looking at the BUN to creatinine ratio can give you an idea of where that is going on.
Thank you.
Yes.
Thank you. I'll give somebody else a chance, and then.
But to also answer about the BUN, so those with really bad kidney disease, like end-stage renal disease, the BUN can be significantly elevated to the point where, we're on question, so it doesn't really matter. If you, like normal is around, you're looking at close to 20, but there are some cases where it gets built up so high that's like 80 to 100, and that actually it's in your system to the point that it actually affects your thinking. And so you become very confused, and we refer to that as uremic encephalopathy. And that is an indication for dialysis.
My question probably relates more to the bladder. It's very common for me to get up 4 to 6 times a night to go to the bathroom. It disrupts my sleep. I often find that I'm sleepy during the day. I really don't want to take a nap, but sometimes I just fall asleep. And so you always wonder, okay, what's going on? Do I have some kind of tumor in my bladder or what? I mean, you know, when you don't know enough about all this, you just imagine things. So do you have any suggestions for the problem I'm having?
There can be quite a few things that cause that problem. We call that urge incontinence, the feeling that you have to, get up and go to the bathroom right now, or you won't make it, or you can't hold it overnight until the next morning. Generally, that's caused by a weakening of the muscles in the pelvic floor. And so there are some exercises that some people find beneficial, but beyond that, it may need to be something that we talk about in an office visit.
Another way to help is, as opposed to using medications, you could also kind of schedule going to the bathroom. So, and now I know it sounds silly, but we refer to it as bladder training. And so if you're having like frequent urination, you can't really control it, you could actually schedule like every hour, every 2 hours, you go to the bathroom, regardless of if you actually have the need to go. And by doing that, you're kind of retraining your bladder muscles and your pelvic muscles. And so you get to a sort of a rhythm. It's like, oh, okay. Then you're kind of fixing that. And then there are other options of having a pessary or a device that hold up the bladder, or having a sling, which is done by either an OBGYN or a urologist, but usually using Kegel exercises or just bladder training is kind of the more conservative way to approach it.
How would I train it for the daytime, but I don't want to do it all night long?
So ideally, You do. So she was asking about bladder training, and so ideally, if you do it very well during the day, and make sure you go to the bathroom before bedtime, and do not drink water or any liquids before bedtime, that should help. And also, when I mean liquids, that also cut down on caffeinated beverages. Oh, you surely complicated things now. But um, something like that, if it continues to worsen despite even trying like pelvic floor exercises, then like a referral to like an OBGYN or a urologist would be appropriate.
I guess we never said we only wanted the easy questions, did we? Darn. Clearly, we take all questions, no matter how hard they are. We don't answer them very well, but we actually, Dr. Malhese did.
Well, I wanted to ask you well, let me preface this by saying that I understand that there is an antidiuretic hormone produced by the brain, and that is under a diurnal rhythm. And if it's working correctly, it will control having to go to the bathroom so much at night. Is that ever a problem in causing that frequent bathroom visit or even lack of incontinence?
Partly. So a common trigger to have the antidiuretic hormone not working properly, alcohol use. You drink too much alcohol, you end up urinating more because it actually inhibits the antidiuretic hormone. As for the incontinence, I am not too sure if it's actually directly related to the antidiuretic hormone specifically. That may be the case, but most often than not, especially as we get older, our muscles sort of weaken and the pelvic muscles can't hold up as well, hence, or the incontinence.
An easy one, okay.
What's the difference between a DO and an MD?
The letters, that's the difference. The training's more or less the same. It is the DOs are trained in osteopathic manipulative medicine, which is not in place of, is in addition to our medical training like the MDs. But at the end of the day, we practice medicine just like any other doctor. That's all you really need to know.
It means that Dr. Joe can do a little better physical exam than I can.
I think it's very comparable, and the licensure and all is identical. So the DOs and MDs have the same medical license in all the states. So very, very, very comparable. I had friends earlier in my career, had friends who were, a couple of friends I worked with who were DOs. And one of them told me about being quizzed one day by a pharmaceutical salesman who he had gotten real friendly with, and this pharmaceutical rep said, "Can y'all just tell me what is the main difference between MDs and DOs? Just your question." And this one friend, very, very straight-faced, said, "Well, really, we see medicine and human health very similar. It's all the same, and the only thing we really differ in is MDs think the heart is the center of circulation, and we think it's the liver. But otherwise, and I think this guy almost fell out. He pulled that off pretty well. I'm sorry? Yeah. Oh, Masters of Arts. So what I stopped short on both of these. guys. In the case of Dr. Hoos, I failed to tell you that he went to medical school at UAMS. In fact, did his last 2 years of medical school up here, third and fourth year. What I failed to tell you about Dr. Malhis is about the MA. While he was in medical school, no less, he wasn't busy enough apparently. He went to graduate school and got a master's degree in medical ethics. Am I right? Yeah, very proud of that. Every doctor should have a master's degree in medical ethics because there are a lot of ethical challenges anymore in our complicated health system. Good question. Yes, ma'am.
If you have kidney disease, is there any research going on that perhaps will reverse kidney disease? Or once you start dialysis, there is no other help for you?
Yeah, that's my understanding. So up until we get to the point where we have to start dialysis, there are some things that we can do to help your kidneys out. We can make sure they're well hydrated, like Dr. Joe was saying. Dehydration is a common cause of kidney injury. So making sure that they have enough fluid to process all of the waste that they have to can help out. And then avoiding some medications that are toxic to the kidneys. Some of those are antibiotics, some of those are water pills or blood pressure medications, but we're thinking about these things all the time when we prescribe medication in people with chronic kidney disease. There are some, like Dr. Joe was mentioning, there are some acute cases where you start hemodialysis just to give your kidneys a break for a short time in the aftermath of an emergency, and you only need it for a day or two, and then your kidneys recover to the point where you don't need to continue hemodialysis. But when we talk about hemodialysis for chronic kidney disease, I don't know of any indication where people are able to stop that after they've started.
You know, I should say, along with that though, that we follow a lot of people who have CKD, chronic kidney disease, at the stage 3 level, maybe sometimes even farther, who never get to dialysis. They never get to failure. So you can have the disease and properly managed, and especially keeping blood pressure under control, and if a person's a diabetic, keeping it under control, and anything else that we can identify that could make it worse. You might be a person who, if not diagnosed, would have progressed eventually to kidney failure, but who never gets there. I'd say the majority of the people we follow never get to dialysis. But it's important to follow them because if they're getting closer, there's still things you can do to keep them from getting there, for a while at least. So, yes.
A while back, I was diagnosed with acidic urinary elimination, and they told me to take the drink alkaline water, and to stop drinking coffee as much as I was drinking coffee, particularly with the whatever's in it, you know, caffeine, yes. And I did that and for a good while, and then several weeks ago I quit doing the alkaline water and I started drinking more coffee, and then I couldn't sleep at night. And finally, I didn't drink any coffee for 2 days with caffeine in it, and I went back to drinking alkaline water, and last night I slept all night.
That's.
But I'm still going to the doctor.
The things that you're doing and not telling the doctor though.
That's right. Well, they came from somewhere. Did you say apple water? No, I said alkaline.
I just came in on the end. I don't know whether you covered this, but I think it's very important for people to know that when your doctor gives you a prescription, call your renal doctor and ask them if it's okay to take, because I have been given prescriptions and the renal doctors have said, oh no, you should never take that. So it's something to really think about when you get a new medicine.
I completely agree with that because there are quite a few medications, especially if, let's just say you're having a infection and you're given an antibiotic. Some antibiotics are filtered through the kidneys, and if you already have kidney problems, they actually may worsen it. And unfortunately, some of these kidney medicines can also worsen your kidneys as well, depending on what stage or how acute or chronic it is. So yes, if you do have a nephrologist you do follow, check with the nephrologist for any new medication changes.
Good point. Other questions? Yes.
Thank you. I understand that if a person is under acute stress or anxiety, that can also damage the kidney. How does that happen?
Well, when the body's in stress, you build up a lot of, I guess, byproducts, including like interleukins and acute phase reactants and what have you. And all that buildup may affect your kidneys because it's got to be filtered through your kidneys. Now, I wouldn't say that one incidence of a stressful episode will trigger a kidney injury. Anytime the body is stressed, that could be from an inflammatory response. You could be suffering from a rheumatological disease. And any rheumatological disease will cause systemic inflammation. That is stress on the body in and of itself. And over time, that could wear away at your kidneys as well as any other organ. But that is not really just like that. It takes time.
Yeah, I would suspect that too, Helen, even though I don't know any literature on that. I don't think any of the organs are protected from the ill effects of stress in some way. We think of, the heart and the brain being especially sensitive to it, but I don't think anything is. I think it's very risky to underestimate the adverse effects of stress, for sure. Yes.
How much water, how many liquid should we have each day, and what counts?
That's an excellent question. It's going to differ from person to person based on what kind of past medical history you have. If you have something like heart failure, then they're going to tell you to limit the amount of fluids that you drink to avoid buildup. But in general, we recommend about 1.5 quarts to 2 quarts of fluid a day. And as long as it's not caffeinated or alcoholic, it counts.
Which doesn't mean that something alcoholic or caffeinated is off limits necessarily, but it doesn't count in the 1.5 to 2 quarts. Perfect answer. That's what I preach every day. Those very 1.5 to 2 quarts of the right kind of liquids. And then in this season of the year we're in now, if you're outdoors, the formula is, in addition to that 1.5 to 2 quarts, if you're outdoors on a day, let's say 80 degrees or more, you need another quart for every 1.5 hours of outdoor activity. So there's always a heckler in the audience.
Decaffeinated is fine. So Coke Zero still has caffeine in it, even though it doesn't have any sugar or calories. But pure water is obviously going to be the best recommendation we have. If you don't like the taste of water, things like Crystal Light or Gatorade, Powerade, other sports drinks, Propel, the flavored water, any LaCroix, the sparkling bubbling waters are fine. Just no
But the
caffeine.
0 Cokes and 0 Sprites and 0 everything's still have caffeine?
So Sprite Zero doesn't have any caffeine in it. As a general rule of thumb, any of the dark sodas,
Okay,
Coke,
7 Up,
Pepsi,
7 Up and
7 Up has no caffeine.
Cherry Limeade.
Those are fine. No caffeine in those.
I mean, you can get decaffeinated colas, but if it's not doesn't say if it's a cola and doesn't expressly say that, it probably has caffeine.
Yeah. The one exception on either side, Mountain Dew is a relatively clear soda that has a lot of caffeine in it, and root beer. Check the label because some of them do and some of them don't, but most root beers don't have any caffeine in them.
I'm so glad for that question because let me just add one thing about the liquids and why this is so important and it's worth preaching over and over again, and that is that virtually everybody in this room, with the exception of these guys, is at an age, I know I am, in which your thirst is no longer reliable. If you only drink when you're thirsty, I can guarantee you will always be a little bit on the dehydrated side. And even mild dehydration robs you of energy. It does a lot worse than that when it gets more than mild. But it's one of the very most important health things that we ought to recommend to every older adult. Some people, the thirst goes away by age 60, but virtually everybody by 70. Your thirst simply won't be reliable. So the first 60 years of life, the thirst is so keen, you never have to worry about drinking enough fluids to keep from being dehydrated. As long as you drink when you're thirsty, you're not going to be dehydrated. But that changes later, and yet we're conditioned to only drink when we're thirsty or have to, and that is a very important thing for the rest of our lives. Tell myself the same thing every day, and hope everybody here hears that and practices that, because it makes such a big difference. None of the organ systems work as well if they're not well hydrated. None of them. And some of them really get you in trouble if you get dehydrated. So, yes, ma'am. Oh, yeah.
So the question was about what kinds of foods should you eat with chronic kidney disease. I think avoiding some of those minerals that we talk about build up in chronic kidney disease, so limiting your dietary intake of calcium or phosphorus, and then making sure that you monitor your electrolytes. So at that point, I would stop recommending sports drinks, things with a lot of salt, things with a lot of potassium. Protein is almost always beneficial. We talked about urinary albumin, urinating that protein out as being an indication that chronic kidney disease is developing. And so anything you can do to eat more protein to help keep your protein stores high will help out for sure. In the later stages of chronic kidney disease, as your body is trying to steal calcium from your bones, making sure that you're not adding more calcium to it.
I think the big thing would not be taking calcium supplements. I mean, still drinking milk, still having normal intake of calcium in your diet's one thing, but once you've got very significant kidney disease, you wouldn't want to be taking a lot of calcium tablets. Oh, sure, absolutely. If you don't have kidney problems, then those recommended supplements are a good idea, especially calcium.
And then Dr. Joe reminded me, since we talked about diabetes and hypertension being the largest causes of chronic kidney disease, if you have diabetes, following a diabetes-approved diet, or if you have hypertension, maybe something like a DASH diet or a Mediterranean diet will also help prevent chronic kidney disease.
I have a kidney issue, but my renal specialist has prescribed calcium acetate in probably pretty massive quantities to most people to remove the phosphorus. So it sort of counters what you just said.
Yeah,
So
so
why,
that
why would I be prescribed so much calcium if it's not good to take it?
yeah, that should, if your nephrologist has told you to do that, by all means, follow your nephrologist over what we're saying.
So calcium acetate in particular is a phosphorus binding agent, and usually for someone like yourself, phosphorus is the biggest issue because you might actually be somewhat hypocalcemic or low calcium, but your phosphorus is the biggest issue. And so yeah, calcium acetate in particular is perfect to help with that. But we're also speaking as general internists, not nephrologists. I think we should have started off by saying that.
Are there other questions? Great questions. Thank you. Helen, you sure you don't have enough? No. Thank you. Thank you. And I want to thank you all, and by extension, everyone who resides here, as well as the staff at Butterfield, for how welcoming and supportive and encouraging you've been to these young doctors in training. Just because I know there's always a little confusion by the questions I hear. These are young physicians. They've as I mentioned, their career and their education. When they come to us, they've just gotten their medical degree, and then they spend the first 3 years preparing to go into practice. So when they finish that 3 years, broadly speaking, there are two tracks they go on to. Into practice, many of them will become hospitalists, many of them will become general internists, primary care physicians, and then quite a few of them will go into fellowships in specialty training, cardiology, gastroenterology, nephrology, any of the medicine subspecialties, and geriatrics. That's right. And because of y'all, there are a few that have declared they want to go into geriatrics. And it's because of y'all, the good impression they have of getting to work with older adults. And that, I think that's very impressive, and I'm very grateful for that. So thank you all for your hospitality and your generosity, and for the privilege of getting to work with you.
Thank you all.